Good morning and welcome to Medical Staff Development in 2021, presented by HSG for OHA, here virtually instead of in person, as we all enjoy in Columbus. My name is Travis Ansel, Managing Partner of HSG. Today I'll be walking you through our views on how medical staff planning should evolve, particularly in kind of this upcoming decade, but with really a focus on what do the next few years look like, and how should organizations such as health systems like yourselves approach medical staff development planning, given everything that we want to accomplish and that everything that our provider strategy really helps us accomplish. In terms of everything we'll be talking about today, there's supplemental resources available on our website. So in addition to the content of today's presentation, if you're wanting to drill into, go down some rabbit holes on different thoughts around medical staff development planning, that's available on our website. But today what we'll be talking about is, a couple of thoughts on how we see medical staff development planning evolving, given all the needs and all the strategic pressures that health systems are under in today's environment. And then talk about some key components that we see being present across most effective medical staff development plans. And then, of course, not right now, but in the future, will be available for questions and answers. And so we'll look forward to those as well. So jumping in here, having been in this industry since the early 2000s, I've seen medical staff development planning evolve a little bit, but we've seen health systems strategic needs and what role provider recruitment strategy. I've seen that evolve a lot for what health systems really need. And right now, we see so many hospitals and health systems focused on access, customer experience, and really when you start peeling those things back, really the deploy, one, having provider resources, and two, how those provider resources are deployed are really critical when we're talking about, our kind of view of having access to the right provider in the right location at the right time and with the right capability, and matching all those things together. That really all comes back to what does our medical staff development plan say, and how are we getting those resources to solve kind of this value proposition. And where we see a lot of gaps is, we see for health systems that are trying to solve this problem, they're doing it in a very disconnected way. We think they're missing the opportunity to kind of centralize their provider strategy, their provider access strategy through their medical staff development planning process. And we think, that really should be the vehicle that says, our growth strategy, in terms of creating access points, in terms of moving into markets, in terms of bringing various specialties to various parts of our market, that really should be centralized through our medical staff development plan, because obviously if we don't have the provider resources to kind of fund that strategy, then it's not going to be successful. And our view from working with health systems across the country is, we still see physician and especially advanced practitioner recruitment as a really disconnected process that's fed by multiple service line leaders, multiple executives, multiple employed physician network executives, and strategic plans across the organization, instead of having one centralized plan that says, based upon the organization's strategic needs in each of these areas, how do those things pull together and proactively identify the provider complement that will enable us to execute that strategy. And so that's what we're really going to talk about today. I'm going to take a 2-slide diversion to talk about organizations that only focus on community need. We're seeing less and less of these, but we still see quite a few. I think medical staff development planning for some organizations is basically running a study of community need, and then basically taking this data and bringing it back to executive stakeholders and service line stakeholders and says, here's what our market dynamics look like from a supply and demand perspective. What do you want to do? Which creates for some very interesting recruitment plans, both in what ends up getting recruited and more importantly, what doesn't, though it is clearly a strategic need. And our view of community need is, it's very useful for understanding your market supply and demand of providers at a high level. It's directionally useful for understanding deficits of provider availability and what the community might need more of. It's extremely useful if your organization is planning on supporting provider recruitment to independent practices in terms of managing your Stark 3 compliance. But it's not useful for building a strategic manpower plan that ties provider recruitment to health system goals, because ultimately, while provider need is a component and a directional data piece, it really is not. It's not one-to-one with our organization's strategy and how we want to grow. So reinforcing that community need is not useful for building any form of strategic recruitment plan. Need can be a component of access, but not necessarily a driver. Need doesn't help address our competitive concerns, because if we're in a health system market, it doesn't really matter who has the orthopedic supply if we don't have our piece of it. So if we're looking to grow orthopedics, it doesn't really matter if the market is supplied. It doesn't matter what the community need study says. If we need to grow orthopedics, we need to grow orthopedics. Overall, it really doesn't consider our strategy and where we want to grow. And it doesn't consider the market that we really want to serve. So if your organization still focuses purely on your Stark 3 definitions, or even a primary secondary definition, those are not usually one-to-one with where we're looking to grow right now. And so having a more comprehensive view that kind of takes your entire market into account, and focusing on the growth strategy and the recruitment strategy that fills that growth strategy would be a little more effective. And from this last bullet point here, community need may have been a little more relevant maybe back in the 90s, back in the early 2000s. But now that we're in a market where, over the last 15 years, where most markets have transitioned back into employment if they ever left, we have most organizations are under an imperative to grow their employed network in the service lines that they want to be most prevalent in, and in that sense, the dynamics of who are we working with on an independent basis versus who's in our employed medical group. A lot of health systems still have a lot of strong independent relationships. But if we're talking about service lines that are core to our existence as a system, or core to our value proposition, or core to our brand, it's valuable to have those independent relationships. It's more valuable to have a stronger alignment. And I know a lot of organizations kind of struggle with where to be on those, do we tolerate the independent relationship knowing it's been a beneficial one, or do we tolerate the risk, or do we move for stronger alignment? But anyways, all that to say, community need doesn't really take into account those dynamics when we're thinking about what our strategy is and how that relates to provider recruitment. So overall, community need informs what we can do related to independent practice support, but it really shouldn't direct anything else, and really should just kind of inform our knowledge of the market. So going into what do we consider to be critical components of effective medical staff development plans, 6 elements for where we are in 2021 and what we think health systems need to focus on. So one, we see a lot of organizations struggling with their historic market definitions. The typical primary, secondary, tertiary, or our 5-county service area, or our whatever definition. We see a lot of organizations using historical definitions that may have been developed 10 years ago, 20 years ago, 3 executives ago, 5 strategic plans ago. Every organization, as we've worked around the country with different health systems in the areas of growth strategy, medical staff development planning, every organization probably should have an idea of where their market opportunities are. And I would say, kind of on this revolving 3-year process, constantly evolve and update their understanding of what their market is, and how, and then have a plan for breaking that market down and making more local decisions. And we'll talk about that in a second. 2, where we've evolved to in the industry, and our ability to understand the entire utilization of care, the care continuum by patients, gives us a real, not just looking at inpatient, state level market, Ohio Hospital Association inpatient market share data, but having an entire understanding of market share across the continuum, inpatient, outpatient, ambulatory, and being able to tie that to how patients utilize the care continuum informs medical staff development planning in a way that really wasn't available, 5 or 10 years ago. And we'll show you kind of our thoughts on how that's best used. Three, we're going to talk about how to effectively utilize community need as part of a medical staff development plan. So talking about supply, capacity, and capability gaps by specialty. Four, touch on succession planning dynamics. Obviously, succession planning dynamics are generally the easiest part of a medical staff development plan from a health system perspective. But given where we are, just with the age cohorts of say our existing physician and supply in the country, and especially here in the Midwest, succession planning is incredibly important because we're talking about large percentages of our medical staff turning over in the next decade. So we'll comment on that a little bit. Five, we see a lot of medical staff development planning, community needs assessment, physician needs analysis, whatever you want to call them. We see a lot of those disconnected from what's our current state. So obviously, if here in Ohio, I struggle to think of any market that hasn't really fully transitioned to employment. Maybe there's a handful of markets where there's still absolutely some dominant independent groups and a few key specialties, but for the most part, we're largely in an employed model, which means we have really good insight into, at least for our practices, what type of access do we have to grow? What type of capacity do we have to grow? And so one of the dynamics we see is, even though we have that insight, our employed network lives in one space and our recruitment and service line planning lives in another. And when we're building a recruitment plan, we don't often mesh those things together to say, well, we have a strategic imperative to grow orthopedics, but all of our orthopedic providers are producing about the 25th percentile. And do we really want to continue adding when we have, probably a year or two's worth of growth in those practices? And so we'll talk about how we look at that. And then finally, we see a lot of organizations, recruitment plans are still, what physicians do I need? And we all understand the dynamics behind that. But I think what we'll advocate for is advanced practice professionals really shouldn't be that thing that we add on anymore. Like, oh, our physicians are getting close to being, having a full panel, close to being in the 75th percentile. We should give them an APP, as opposed to proactively identifying what's our ideal practice mix, what's our ideal practice model, and proactively building that, and not adding APPs as overflow or as additional bandwidth, but as a key part of that model, and that's something we'll talk about as well. Okay, so let's start with tailoring market definitions. As I said before, most organizations are still relying on kind of that historic primary, secondary, tertiary market. As care becomes more local, our view is as we're looking at health systems competing with one another in the same market, the more locally we can provide care, the more locally we can provide access. We really think that that's the winning strategy. So that requires our market assessment, our physician need assessment to become more granular as well, and not just on a primary care basis, but really for specialty care as well, because I think we're seeing around the country, the more that we can bring our specialty capacity to local markets, whether that's specialty clinics, whether that's, the dedicated practices, whether that's, ambulatory surgery centers, whatever it is, having that as a more targeted local care delivery makes sense. But that means our market definitions have to evolve to support that. And when doing that, creating, more what we call market clusters, can help us think more about our local provider strategy and in turn help us build an effective recruitment plan. So what does an example of that look like? This is a blinded example. Of course, you could Google the zip codes and figure out what market this is. But of a market that's clearly not a primary, secondary, tertiary market, but one that's really more targeted around, when we help build more strategic markets that are a little more local, thinking about how do patients travel through a market? What's our health system's historic penetration of a market? Where are demographically similar groups that tend to utilize healthcare in the same way? Where are they located? Where do we have common competitive threats? And what's our relative strategic priority for development, absent of this process? And then bringing together zip codes in order to create kind of submarkets that allow us to be a little more targeted and think a little more locally into how am I delivering care in these markets? What specialties am I bringing specifically to these markets? And what's my geographic strategy? What's my access strategy? How am I building a geographic footprint? And then that all informs us. That all informs, kind of how our provider strategy might evolve to bring care a little more locally. When we break markets down into kind of these clusters of zip codes, we have a rubric that we developed really that as we bring together other data to support a medical staff development process, like looking at our penetration of primary care in a market, our market share within a market, how our competitors are doing within that market, what access we have to specialty care and acute care from our system's perspective in a market, and overall, what do the demographics of the market look like? We basically created four functional buckets of how do we roll those clusters together and get a sense of prioritization. And most commonly, what we're looking for is, well, in the areas that we're strong in, so we've got high primary care penetration, we already have high market share. Our competitors' penetration of the market's not really significant, and we've got reasonable access to our specialty care and our acute care. And it's demographically a market that's attractive and we want to continue to have high system market share in. That's what we call a reinforce and defend market. So there we're looking to address gaps in the provider supply using community need maybe, to ensure that our market position does not degrade. We're looking to make sure care is delivered as locally as possible, and we don't create opportunities for competitors to move into our market and fill a gap. And then secondly, we're looking for strategic growth opportunities where we've got reasonable access to our system resources. We've got demographically attractive markets, but where we haven't made investments, we haven't had historic success, and our competitors also haven't had historic success. So these tend to be markets where they tend to be suburban markets, I think is probably the best way to say it. Developing markets where healthcare has not yet pushed out to meet growing, new development of housing, new development of jobs. So that creates a different opportunity. So that's how do we move into that market, and what provider resources do we bring to fill that developing need. Third, we have markets where maybe historic resources just haven't existed because of demographics or because of location. These tend to be maybe more rural markets, markets that are a little even when you aggregate them together, don't create large groups of population. In a fee-for-service world, does it make sense to bring services out to those populations? Maybe not, unless not from a ROI, not from a business plan perspective, maybe from a mission perspective. But as we're talking about pushing more into a value-based environment where we're seeing payers evolving And again, taking this to Ohio, not seeing it as much as in some other markets. But as we expect payers to continue evolving incentives for more population health, if what we're after is lives capture as opposed to commercial market share capture, grouping together markets and being able to say, this isn't a market that we're going to chase because of the demographics, but because we really our goal now is evolving from pure volume to lives capture. It makes sense to be able to proactively identify what markets look like that. And then the last one that we'll focus on is looking at markets that we aren't a part of yet. So we've got low penetration, we've got low system market share, and a competitor reasonably owns that. But it's also markets where we've got favorable demographics and reasonable access to bring patients back to our specialty care and acute care, which is what we call a penetrate highly competitive market cluster. Sometimes, more often than not, we use this to talk organizations out of allocating resources to direct competition and really focus on one and two here. But often there is an opportunity to really think through, okay, if we're going to move into a market that we have not traditionally owned and is owned by a competitor, how do we size our resource needs? Because then we really aren't focused on community need, are we? We're focused on, we want to strategically come into this market and disrupt the existing dynamics of competition, which means community need be damned, really. We need to bring resources to that market. And so understanding what markets those are, so that we're not blindly moving into a highly competitive market, and then being able to size our recruitment needs in order to fulfill kind of our strategy to disrupt an existing market is extremely critical. Okay, so moving on to number two, which is understanding utilization of the care continuum by patients within the market. So as I noted, there's a lot of opportunity created by the advancements in utilization of claims data over the last 10 years. Maybe that's too long of a time frame. Maybe it's really more than the last 3 to 5. But we still see a lot of organizations evaluating market share on an inpatient only basis. And we think this creates a lot of blind spots in the area of what's going on in outpatient and ambulatory, because as we're really thinking about what drives inpatient market share in today's environment, it really is what's going on the outpatient and ambulatory side. So if we don't have arms around that, then we're really hoping that patients end up showing up at our door, as opposed to being able to measure what's going on in the outpatient ambulatory environment and knowing that patients are going to be end up in the hospital or utilizing the health system services. When we talk about this, we really focus on patient share of care. So, of a patient's total health care spend, inpatient, outpatient, ambulatory, what percentage of a health system, what percentage of that dollar is the health system we're working with? What is their capture of it? Which we think is critical to identifying, gaps in our delivery of overall care. Because if we say, we're capturing within our market, we're capturing 25% of total patient spend, and maybe within our primary care patient panel, we're capturing 70% of total spend. That still begs the question, well, what is that other 30%, and where is it going? And if we have a patient spending 70% of their healthcare dollar with us, but we see that they're not utilizing I keep saying orthopedics, but orthopedics is a great example. If they're utilizing us for most other services, but directly going around, our orthopedic offerings and having orthopedic care delivered by a competitor or third party independent group, that's very helpful for understanding where we have gaps in either provider resourcing, access points, brand marketing. It's very, very helpful to understand what we're not getting and start building a case as to why. And then, overall, where we're evolving to is, whereas 10 to 15 years ago, provider recruitment plans, again, may have focused on addressing community need, where we're trying to evolve health system thinking to is provider manpower, medical staff development planning should really focus on how do we support the increased incremental capture of the total patient dollar, because obviously, regardless of whether we're in a fee for volume or fee for value system, what percentage of the dollar or even what percentage of services we're capturing from a patient really identifies where our gaps are and what opportunity there is to kind of fill in and understand, how do we keep that patient completely within our system as warranted. So what does that look like? Here's a great example, from a large market, obviously blinded here, for a market that's got about $8 billion in spend to it. This health system, is controlling about 23% of the overall total patient dollar, broken down. That was, a little higher on the commercial, a little less on government and other payer side, which, great for them. But so that overall, it's a nice measure. It's a great measure to be able to track over time and say, are we doing incrementally better? But it gets a little more helpful when you start thinking about it down at the site of care level. So how are we doing on the inpatient perspective? How are we doing on the outpatient perspective? How are we doing on physician office visits perspective, which is something that a lot of health systems have a blind spot to, as well as the ambulatory side. But for medical staff development planning, where it's probably most relevant is really drilling into our service lines and understanding variation therein, right? So if we're looking at cardiovascular services and we see we're capturing 24% of every commercial patient's dollar, but in general surgery we're capturing 30, and in GI we're capturing 15. Well, that's quite the variation, isn't it? And in this particular client, it's because they were very weak in GI. They didn't, they couldn't size how weak they were in GI, but being able to measure, the dollar impact of being here at 30% versus being here at 15%, you start looking at that. That's a pretty big spread in terms of dollars. Same thing. We're doing very well in spine. And very well in neurosciences. That's something that we can continue to build on, extremely well in cancer. So looking at the variation of how we're doing by service line starts to give us some direction. And then we can, drill down even further and say, okay, within each of these service lines, and this is where it gets really exciting for medical staff development planning, how are we doing, kind of within each component of that service line. So, you look at the variation in the share of care numbers. This client obviously doing a very good job at pushing cardiovascular patients back towards diagnostics, but in terms of the overall care delivered, maybe not as great. Breaking this down, looking at cardiology as an example, medical cardiology being at nearly 30%, but having our EP and cath business be at 17, between 9 and 17%, really belies that, hey, we either have an access problem in EP and interventional, or we have a supply problem, or we have maybe a brand problem. And I think in this case it was really a supply problem, which helped inform that we really needed over the next 3 years to build up our capabilities, because even though we controlled more of the medical cardiology market, that's still not feeding our proceduralists. And so that's an example of how we see the integration of a total picture of the care continuum being extremely effective for medical staff development and planning. And and as I mentioned, maybe over the last 5 years, we've seen this go from this is a nice piece of data as we've started kind of building in claims data to really help identify the market. 5 years ago, this is really nice. Now I would say it's really critical, because we have to understand this at the system perspective. I mean, regardless of medical staff development planning, we have to understand these dynamics. But taking it down to medical staff development planning level, being able to identify this type of gap, and that we're by not having the access and the supply we need in kind of our procedural cardiology, that's costing the health system real dollars. Two, as we evolve into a more of a value-based environment, these are patients that are likely going to be seeking care outside of our system, which in most cases is going to be to our detriment. All right, so 3, identifying supply capacity and capability gaps by specialty. So you heard me talk poorly about focusing only on community need, but when used as a directional indicator, it can definitely be a useful data point to consider when building a strategic medical staff development plan. It's good at giving context to other data points as we're pulling everything together. It should not be, as a reminder, should not be used to justify strategic need. We do find that community need, if we can make a market more granular. So going back to our, we really need to look at markets from maybe a cluster perspective and not a primary, secondary, tertiary system perspective. The more granular we can utilize community need, more granular a market is that we apply community need data to, more effective that data really can be. So let's use an example of primary care. So looking at this is an overview of how we look at primary care in a market, and with this. What we like to do is compare markets of similar size for key specialties, and basically say, for markets that are between, in this case, 1 and 2 million people, here's what our actual supply of primary care is in your market. Here's what our demand models might say you should have per 10 or per 100,000 population. Here's what the U.S. just across the U.S. Here's what the current supply is per 100,000 of population within your state, and this stretched across 2 states. Here's what the relative supply of primary care is per 100,000 population, and then here's, based upon 30 other similar metropolitan regions, here's what primary care looks like. So this market was using this type of metric very clearly deficient in overall primary care. And that flowed through to looking at their community needs studies, where we saw in their markets, unaddressable amounts of primary care need, really requiring some level of prioritization, and really thinking about how we deal with some of those dynamics. And that's where we find that to be really example. And then you can do cool things like bring that into our market, and as I talked about, focusing on granularity, being able to target areas where we have more intense need for something like primary care, and understand, kind of where the competitive areas are. If as we match, these types of deficits to our studies of markets, studies of demographics, and start prioritizing markets, if we can find attractive markets that have a dearth of primary care supply, that becomes that looks like a really great match, doesn't it? So that's how community need can be useful. Again, it's making it granular, it's giving it context, and it's not just doing a community needs study and saying, hey, our market needs 50 primary care docs. What do we do? Okay, so number 4, identifying succession planning dynamics by specialty. I commented on this a little bit earlier, but we're really seeing across most markets, every time we have done a needs study in the last 5 to 7 years, you can just see the coming wave of physicians who are approaching age 65, and that percentage just keeps going up and going up. And it really creates a challenge for maintaining supply. And what we're seeing is generally 20 to 30% of a health system's medical staff could be at risk for retirement in a 5 to 8 year time frame. We generally start evaluating age 65 as kind of that, maybe the provider is not going to be retiring at age 65, but we need to start planning for what the future looks like, and having recruits in the pipeline, and having a forward-thinking plan about what are we going to do with those patients and those providers to ensure we have continuity of care. And so putting some context to that, again, some sample data, this particular client and their medical specialties, has 22% of their medical specialties are aged 60 to 60 plus, by 2022, 35% of their primary care providers, by 2022, 27% of their surgical specialties, and 28% of OBGYN. So, and most 20, at the low end, 22, at the high end, 35, looking at these cohorts, big percentages, that as we're talking about trying to execute our incremental strategy and grow, we have to take a step back and say, hey, we've got a lot of work to do just to maintain the status quo. The good news is, I mean, obviously that every other health system's in this boat as well. We're not seeing massive variation in age dynamics between systems and competitive markets, but it still portends a huge challenge in figuring out how we address these needs. And again, it goes back to what we'll talk about last. How do we utilize advanced practice professionals? Because this is an almost insurmountable, for this client, an insurmountable challenge to fill all these FTEs purely with physician recruitment. And you can apply data to that, so you can see for this client what those numbers actually look like. 58 FTEs in adult primary care above 60. I mean, that's just a scary number, isn't it? I talked earlier about number 5, defining existing capacity within the health system's network of practices. So, everything moving towards employment gives us insight, at least into, for a number of key specialties in our market, how much capacity do we actually have? And, as we're talking about growth plans and trying to grow our volumes in particular specialties, how much of that can we do with existing resources before we need to dip into incremental recruitment? Which is a great question to ask, right? Because recruiting providers is very expensive, not just bringing them here, not just paying them, but everything that we have to do in order to make them successful. So if we can continue our growth organically without having to make additional incremental additions, that would be great. So if we look at that, as I mentioned earlier, we tend to see a lot of disconnect between employed network leadership and looking at incremental provider need, which is usually owned by planning or recruitment within a health system. Some organizations have better communication between those functions than others. We generally espouse a philosophy of, when we're looking for incremental access for patients, we should start with how can we better use our existing resources before moving to how many provider resources should we incrementally add. Again, just the value proposition of maximizing resources versus adding additional ones. And then, when we're talking about this, measures of productivity, time to third next available appointment, anything that we have that gives us measures of internal access should be evaluated from our current group of providers before we think about recruiting more. And in addition, this is one of the flaws of community need. I maybe didn't comment on it earlier, but if we have a bunch of providers that are maxed out, that are not taking new patients, and this is especially true in a lot of markets for primary care, at least it feels like it recently in the last few years. If we can say we have all the primary care supply that we have, and it's great, but if they're all not taking new patients, it really doesn't matter. They're functionally not there anymore because as we're looking for, to address increased demand from new patients seeking care, those providers aren't helping us provide that access. So having plans for what we do with practices that have a preponderance of 75th percentile productivity physicians is critical as well. And so here's an example of what one of those clients or one of those health systems might look like, where if this is the 50th percentile in terms of work RVU production, you can see clearly this organization probably pretty happy from their existing utilization of providers. But what this also portends is when you have 40% of your employed group, above the 75th percentile, you might say, wow, that's great. We're probably minimizing subsidy, but what we're doing is also minimizing access, right? And if we drill that down to primary care only, instead of looking at the whole provider group, what we see is that dynamic even magnified now, where we have 52% of their providers over the 75th percentile. And we start applying that to our, again, the granularity of looking at a market and applying it to our market clusters. In our southern market, we've got 60% of the providers over 75th percentile. In our north market, we've got 91% over the 75th percentile. So this really helps us identify, one, not only do we need more primary care, absent of what the community need models say, we as an organization need more primary care because the markets we want to serve are not being well served by our physician, or not incremental access is not being well served by our existing providers. But it also helps us target where we need to do that. And then going back to, how do we use other resources more efficiently? If we're looking at something like the central market, we're still, almost half the providers are above the 75th percentile. We also have, a growing number of providers that 36% that are still below the median. Another dynamic down here in this Southwest market. So this really gives us a feel for, this is maybe more of a market where the southern market, this northern market, maybe even this eastern market with nearly 80% above the median. These are markets where we really need to add access because we know our providers are going to be slowing down in terms of the number of new patients they can bring in. And maybe these central and southwest markets are, despite our perceptions of what our primary care strategy is for them, we have a lot of existing capacity. And so then the question becomes, why do we have so much capacity? Do we have just fundamentally unproductive providers? Do we have bad practice dynamics? Do we have bad locations? Should we expect the practices to continue to grow in their current location, or do we need to relocate them? Or do we have providers that maybe ultimately we need to divest and we need to recruit new? These are the questions that this type of analysis really helps identify. And another interesting way to look at this from a medical staff development and planning perspective is, for each of our core specialties here, if they're not producing, if we got everybody up to a certain level of productivity, 40th, 50th, 60th, 70th percentile, what would our incremental work RVU production look like, and how would that move us, to what would this chart look like if we actually, kind of moved everybody to that, and in this case, moving everybody to the median, would be generating, about 193,000 incremental work RVUs, which you can, work that back out to how many work RVUs per visit, and you can understand how many more visits you can accommodate, per specialty. But this type of analysis really gives us an idea for, okay, how much slack is really available within our system, and how do we, what else should we be doing besides recruiting to increase access and get providers up towards these standards? And the last thing I'll talk about is defining the ideal mix of physicians and advanced practice professionals. So we've hit on APPs in a couple areas. I think it's most critical, and as we're looking at supply gaps by specialty and thinking about the coming wave of providers that will have to be replaced over the next 10 years due to retirement concerns, the role of the advanced practitioner, in a lot of markets, we're definitely seeing the role of the APP evolve and being viewed less as an extender, and we're seeing the word mid-level go away, and then being viewed as a critical provider to care delivery within the practice setting. But what we continue to advocate for is, we should be proactively identifying our APP needs rather than reactively doing so when physicians are starting to max out and APPs become we really should add an APP to that practice, as opposed to an APP is a critical component of our practice, which we're going to proactively identify, and our physician and our APPs are going to grow together. So how do we evaluate that? Again, commenting on, APP recruitment's more of an operational activity in a lot of health systems rather than a strategic one. So it's not something that gets identified in the med staff plan, but really gets identified maybe by your employed network leadership, or maybe by your physician leadership council. But, as more of an operational activity, we tend to advocate recruitment of APPs as a strategic one. With a great example, Dr. Smith's getting close to capacity, we're going to add an APP. That's what we see right now, but not what we would advocate for. Given the shortages in most key specialties, we really think APP recruitment and utilization is going to be a strategic driver of care delivery and patient access. What do we see as common barriers for APP utilization? So in a lot of markets, and even in a lot of large and sometimes urban markets, patient acceptance. While we think patient acceptance has certainly improved over the last decade, we still see some barriers there. Care delivery model, I think, is care delivery model and compensation model are usually the two biggest barriers. So one, do we have an effective model for utilizing APPs, which really gets to, if we've bought a practice, brought it into an employed network 15 years ago and decided to leave it alone and not really actively manage it and transform the way the care is delivered in the practice, throwing APPs into that practice is under that physician or physicians probably not going to be as effective as proactively designing a care model within our practice where APPs are there at kind of central to care delivery. I mentioned compensation model, which I think is one of our biggest, as we work around the country, one of the biggest barriers we see to effective APP utilization, because we still see a lot of pure productivity models, and particularly a lot of individual pure productivity models applied to employed physicians across the country. Not the best model for creating an effective physician APP relationship. When we start disincentivizing the ability to share patients, when we don't look at everything from are we using everybody at top of license rather than, is everybody just kind of getting what they get? That really becomes a challenge for effective APP utilization, and usually can be fixed by adopting a compensation model that maybe minimizes or lessens individual productivity and more focuses on team-based or group productivity, and also kind of contemplates, forwardly thinking, contemplates what that relationship between the physician and the APP needs to be within the practice setting, so that we're not disincentivizing physicians to utilize APPs effectively. And one other barrier, which we still see in some markets, is just a lack of the physician culture not really being supportive of APP utilization. And it's really interesting, working across the country, seeing how this varies from market to market and even health system to health system. There are just some cultures that where either physicians don't have a positive frame of reference, or some form of negative frame of reference for working with APPs. There's a lot of variability in the perception of education and training by physicians about APPs. So that's all. We're not recommending a fix to that right now, or in this presentation. There are ways to take that on, but noting that these are generally barriers. Where do we see service lines that typically use APPs well? So in general, we think just about every specialty can be supported well from an APP perspective. The most common ones are primary care, behavioral health, orthopedics, cardiology, and neurology. I mean, that, again, this is, where do we see it most commonly? We certainly see OBGYN, certainly see oncology. It's a great way. Rheumatology, I mean, pretty much every medical specialty has the capability to support APPs really well. So, on the surgical side, again, it's really physician frame of reference and kind of work pattern. We see for basically every surgical specialty. I can give you an example of a provider or a practice that utilizes APPs very efficiently, but on the whole, with maybe the exception of orthopedics, it's not as common as primary care or medical specialty care. So what do we? So we all agree that that's a great process. So how do we bring it together? Again, we tend to see health systems developing any form of medical staff development plan or recruitment plan in a pretty disconnected fashion. I would advocate that your medical staff plan or recruitment plan is probably your second most important strategic plan within the organization, other than the health system plan, and should be approached very much in the same way. So we have our organizational strategy. How do we build our provider strategy to help us execute our health system strategy, which brings in together all those same people, a lot of the same people, that you might focus on from a health system perspective. What you don't want is multiple executives executing multiple recruitment strategies, which result in likely a strategy that's not aligned. And when we see not aligned recruitment strategies, we tend to see that tends to mean, one, we're failing to help execute the overall health system strategy, and two, we're going to make a lot of mistakes with recruitment, which ends up being very expensive. And what should it look like when it's done? Well, we should have, for each of our core service lines and specialties, we should know, one, what are we recruiting in total? What's the variation between physician and advanced practitioner? And where are those resources being placed? So again, getting out of the, well, we just need 3 rheumatologists and we're going to figure out what we're doing with them. Proactively thinking about where are we going to place them. Same thing with primary care. Same thing with any specialty, really. What are we doing with them? So anyways, that's our time for today. I thank everybody for their virtual attention. I believe everyone has the chance to send questions through the presentation app. So you're welcome to send those. They will come to me. I think I understand by email. I'll be happy to respond to any and all of those. And with that, I'll say thank you for your time, and I'll look forward to interacting with everybody in June. Thanks a lot.